Hello. All right, can y'all hear me?
Yes.
All right. So go ahead and put your name in the chat. Tonight, we're going to do it a little bit different, but we are still going to be taking notes. But this time, instead of me just talking the entire time, it will be a little bit more interactive. So as we're getting to different slides, I'll call names and ask you, based on your readings and your studying and also your homework assignment, which I know a lot of you are already working on. Um, what is your take or interpretation of some of these topics? Share this. I think I lost somebody. Where's my share? Aiden, Nuvia, Dylan, Shelby. Let's see. All right. Are you able to see my PowerPoint? Okay. All right, so this is chapter 8. And chapter 8, some of the stuff in chapter 8 went back to some of the earlier things that we learned. But this is on medical imaging equipment. So it's kind of breaking down the X-ray unit itself or the parts of the X-ray unit itself. And then it goes into some of the other modalities, potentially some that you might be interested in after you take your boards and you get your diagnostic registry behind you. Maybe you want to go into some of these other modalities. So I'm not going to do, again, all the talking tonight. I'm going to be asking questions to gain your interpretation or what you felt that that particular slide speaks on, or that particular piece of equipment, what exactly was it for? And so we did have a lot of objectives. So differentiate between two terms that they gave us: diagnostic yield versus diagnostic efficacy. Identify the typical features of a rad fluoro system. Explain the manipulation of your X-ray equipment. Explain the purpose of collimation and the importance that it holds in terms of radiation protection. Distinguish among the various types of radiographic tables and their functionality. It went over two different types of tables. Explain the major controls of the radiographic system control console or generator, so to speak. Differentiate between the types of X-ray tube supports. It talked about two. Explain the purpose of the upright image receptor and its functionality. I like more so the term upright Bucky, but our book says upright image receptor. Discuss the concept of alignment of the various radiographic system components. Outline the clinical considerations of modern DR detectors, kind of something that we've talked about in the past. And distinguish between the two general classes of fluoral system designs, which are fixed and mobile. Discuss mobile radiographic systems and why we use them. Explain the basic operation principles of some of the more advanced imaging modalities, and briefly outline the distinguishing diagnostic yield characteristics of the different imaging modalities. All right, so the first thing our chapter kind of talked about is diagnostic yield. What is diagnostic yield? What does diagnostic yield mean to you? So basically, for me, can't talk. Diagnostic yield is basically asking how much information is that actual x-ray or procedure giving you in terms of, what the doctor needs from that image. All right, what image is it giving you? um is it good enough to assist with that patient's diagnosis? In most cases, different imaging modalities are going to give you different information in terms of diagnostic yield. So when they're ordering these different exams, they have to take into consideration what is it exactly that they want to see? What information is it that they're hoping to gain? So in terms of radiography, it's really good for things like bone, looking for fractures and things of that nature. Whereas fluoro is really good for what we call dynamic imaging. We're kind of looking for the function of something. So if I was doing a swallowing study, I'm able to see the patient take the contrast in their mouth. I'll see it travel all the way down to the stomach. And in some cases, I can even see it start flowing through the system if they're taking it from the mouth. And then we can do it retrograde and do what we call a barium enema, take the enema up the back way and see how it traverses through the patient's colon. All right, in terms of sonography, some of you may be interested in sonography, even though this is not the typical path to get to it. ART does have a sonography credential, even though that's not the one that's most sought out. Sonography does not use radiation. They use sound waves to generate those images, and it's really good for things like soft tissue. It's good for, of course, what it's really known for is you're looking at a fetus as they progress or grow within the patient. And then it's also good for vascular things like looking at different types of blood vessels within the patient. CT, that one does use X radiation a lot more than regular X-ray because the X-rays are more, and that particular exam is going for a longer period of time. Basically, X-ray is milliseconds, whereas or seconds, whereas CT, it can be 15, 20 minutes or more, depending on what type of exam it is. So with CT, it's really good for, of course, soft tissue. It's really good for 3D imaging as well versus just the 2D imaging. But again, it's a lot more radiation for the patient. Um, MRI, CT gives us more detailed images and it slices the patient. So instead of just seeing just that 2D image, I can see different slices at different levels, almost like slices you like a piece of bread. It can slice you from front to back, or it can slice you from top to bottom. And I can take that slice and I can look down on the individual slice and get down to the actual slice that is being affected. MRI, very detailed, even more detailed than CT. Very good for looking at things like tissue, such as brain tissue. Joints are really good to see. And then also, what else is MRI good for? Joints, soft tissue, brain tissue, etc. A lot more expensive. This one does not use radiation either. It uses radio waves and a very strong magnet to produce those images. Of all of those other previous modalities, that one is a lot more expensive, so it wouldn't be the first one that we choose. CT wasn't even the first one that we used to choose, but now it seems like everyone gets a CT that rolls in the ER. But a lot cheaper than MRI, and a lot shorter time with the patient than MRI. MRI is more so scheduled, whereas all of the other ones, they can be more emergent. Fluoro is typically scheduled too, but there are times when, let's say we have a ward patient, they can put that one on like an add-on at the last minute. And then the last one right there is nuclear medicine. So with that one, it's another modality you can go into. They are injecting the patient with radioactive tracers or nucleotides. Those tracers are attracted to wherever the issue is. So once they inject it, they use a gamma camera to detect the radiation that's coming off of the patient. So in this case, the patient is the source of radiation. Does have very short half-life, so um, eventually the patient will get rid of the radioactive nucleotide. A lot of times when they urinate, it can leave their system, but very short half-life. But again, those images look like really fuzzy images. If you were ever in an art class, there was a type of art that you did where you create the picture with just a bunch of dots. That's what those images kind of look like for nuclear medicine. But all of them are going to give us different information. So we wouldn't choose a nuclear medicine study if we were looking just to see a bone fracture. We wouldn't choose well, you get what I'm saying. You wouldn't choose a nuclear medicine study if we were just looking for a bone fracture. So with diagnostic yield, whichever one that you choose, not only does it need to give you the information, give them the information that they're looking for, it needs to make sense in terms of the quality of the images that it's going to give us, and then in terms of the costs as well. All right, so that is what diagnostic yield means to me based on my readings. All right, each modality again has its own considerations for ordering the procedure. So again, the exam type that is chosen by the doctor needs to be able to yield the information that they are looking for. So if they're looking for a bone fracture, they should probably choose first X-ray. If they're looking to monitor, a baby, they should probably choose sonography or ultrasound. So again, if they're looking for, a brain bleed, or something going on with the brain, they should probably choose MRI. So again, they are in most cases not necessarily trained to know, but they have a little bit of knowledge of which modality is going to yield them what they need. If not, they can always consult with the radiologist to see which exam is going to give them the information that they need to diagnose the patient. All right, diagnostic yield of information must outweigh the input factors of the procedure. So that's going back to something called the benefits of that exam needs to outweigh the risk. So let's say I have a pregnant patient. She was in a car accident. She's coming in and we feel that, she might have some internal bleeding. Now, we typically would not CT or don't even really want to x-ray a pregnant patient. But at that point, if we're looking for something that could put the patient's life at risk, the risk of having that exam definitely, the benefits of having that exam definitely outweighs the risk. We need to see what's going on with the patient, and then next we need to see potentially what's going on with the fetus. All right, competent imaging professionals will strive to maximize diagnostic yield using a minimum of input factors. So one of the things that we should be practicing in the simulator, I know right now it's more so like, oh, I just need to give this image for a grade, and we don't really concern ourselves with the quality, but we actually should be concerning ourselves with the quality because we're practicing right now. You need to ensure that all of the information that needs to be on the image, meaning if we're talking about a chest x-ray, from the apices all the way down to the bases needs to be included in the image so that we can get the appropriate appropriate diagnosis for the patient. If we're missing information, then of course, we just did the patient a disservice because we have to repeat it. So again, remember the term as low as reasonably achievable, or ALARA. When did you hear that term? What portion of, or why is that important to you? Anybody can answer.
It keeps the patient from getting any additional radiation that is indicated.
Okay. So as Shelby stated, if we do it right the first time, and of course, if we practice what we pledged, which was image gently and image, how was it, wisely, we want to use the lowest dose possible to yield that diagnostic information that's needed to diagnose the patient. So, that is my interpretation of diagnostic yield. All right, diagnostic yield and diagnostic efficacy, they kind of go hand in hand, because with the efficacy, we know we need information. Now we need to know the image that I took, is it accurate enough to get the information that we need? So diagnostic efficacy is making sure that everything that is supposed to be within that particular image is there. If it is not there, then we need to repeat it so that the patient can get their diagnosis. All right, if it is inaccurate, meaning, let's say there was some sort of artifact. Let's say there was motion. Let's say there was model, or what's the new term for model? Noise on the image. Those are things that we need to take into consideration. And if it is detracting in terms of there's something missing or something that may be hidden based on what we image, then we as a technologist, we need to go ahead and repeat it. Again, if we're just taking the image and all of the things aren't there. So one of the things I can attest to in Georgia, pretty much anybody can take an x-ray. So MAs, nurses, even people that may have not graduated x-ray school, let's say they started, they got some training out in clinic, maybe they didn't make it all the way through. They can get jobs in, not saying they would stay at or do it at a hospital, but let's say our urgent care facilities, and also some of our ortho places, they can get jobs. So an MA isn't trained unless someone took the time that had the training. They're not trained to know exactly what should be there. So some of the images are just taking images just to charge the patient, because you look at them, it's like, oh, that's grainy, or we don't even have the complete chest on there, or that's not even a position that we would take for that procedure. So not only does the information need to be there for us to get the diagnosis, also the information has to be accurate. So everything that needs to be included for that diagnosis needs to be there. So those two terms kind of go hand in hand, in my opinion. All right, now we're moving on to X-ray machine design features. All right, so these are some of the things that they say our X-ray rooms will have. So the room will have an X-ray tube and an X-ray tube support. Within the X-ray tube, we'll have a collimator assembly. The room will have, unless of course it's just a chest room, it will have a radiographic table. We will have an X-ray generator and control. I think the word that's missing there is console. And then we will have an upright image receptor. I think it really should read upright Bucky versus image receptor. So these are some of the things that our X-ray rooms typically will have, unless of course, like I said, if it's a chest room where it just has a tube support and your upright Bucky, or has an X-ray generator, it doesn't have that table. All right, now we're gonna go a little bit into the X-ray tube design itself. So I'm just gonna go down the list as we're going through these slides and kind of ask you, based on your readings, based on your study, based on your project that you're working on, what some of these things mean to you. So in terms of X-ray tube design, um, what would you say? So Shelby already asked a question, so this one's gonna go to Nuvia. Nuvia. What would you say, that's because your picture's first on my screen, is the primary purpose of the X-ray tube for you?
For me, it would be first the equipment that I'm going to use to take, to give a care to a patient. So the two would be, okay, this is the camera, so I'm going to take this picture with this camera, and I just have to read the labels and make sure that I can understand each of the labels so I can protect the patients from unnecessary radiation.
Okay. So basically the X-ray tube, that's where the X-rays are produced for that patient's exam. So the X-ray tube itself, you can't see it, but it is inside of what you actually do see. The little box that you see, it is lined with lead. The housing is lined with lead. And the reason it's lined with lead is what lead does, it has a high atomic number. It blocks those X-ray photons, what we would call the stray or off focus radiation. We only want the radiation to exit out of the window, which is the part that is facing the patient. Now, all of our tubes do have a certain amount of leakage radiation that they can have by law, but in most cases, everything is exiting from the window. Now, the part that you can't see is the X-ray tube itself. It is made of what they call a heat tolerant material. It lists here Pyrex. Anybody heard of the term Pyrex before today?
I never have.
Nobody has heard of the term Pyrex. Not
Like,
you, Shelby.
Brand of cookware I know.
Cookware. Right, cookware, Pyrex. Some books use the term borosilicate glass. So that is what the tube is made of, and is actually a vacuum, meaning it's evacuated of air. So as those electrons are flying from the cathode to the anode, it doesn't encounter any air and potentially cause arcing. All right, so X-ray production is very inefficient. 99% when we're taking those X-rays is heat, 1% is X-ray. So we need a heat tolerant material, which is Pyrex, to deal with that heat. So it stands up to the heat, very heat tolerant. So that is what the actual X-ray tube itself is made of, and you can't see it because it is in that lead-lined metal housing. You only see the housing. All right, again, the purpose of the tube is to produce those X-rays. And those X-rays are created when those electrons that are created at the cathode fly across to interact with our anode target. Once they interact, they are either stopped or they're slowed down, and they produce the X-rays that are needed for the patient's exam, which are either bremsstrahlum in nature or characteristic in nature, which is not within this particular lesson. All right, the X-rays that are created we want them to exit through the window, which is facing the patient. So when you go to the actual, I don't know if we can see it on the simulator, but if you were to look underneath the tube, you will see it's like a plastic window. And on the plastic window, there's a crosshair that tells you where the center is. You can't see within there, but inside of that also is where the collimator is housed, and the collimator is made up of, lead shutters, a light source, and also mirrors to reflect the light to show us exactly where we are. So wherever the light is, that is what is going to be in the image, unless, of course, we are using the Bucky and we're not detinted properly. But in terms of anything that is tabletop, wherever you see the light, that is what is going to be in our image. All right, our collimator assembly. So again, the collimator is part of the X-ray tube. Shelby already answered. So next is Lacey. 'Cause I think Dylan answered a question. Lacey, what would you say the job of the collimator is?
The collimator, is that like when you put the light on the patient, you have to like adjust the width and the height of it? Can you repeat the question again?
What would you say the job of the collimator is?
I guess it would be to like make sure that like it's getting the correct, like, I don't know how to explain it. Like it's hitting the right spot, if that makes sense. Like it's hitting.
So the collimator basically controls, in a sense, how large or how small the X-ray beam is. Basically, like you said, in your simulator, it controls the area that's basically lit up. We don't want to X-ray too much, nor do we want to X-ray too little. We want to make sure that everything that's supposed to be in the image is there. But as you can see, sometimes when you, let's say you rotate the tube up towards the wall, and you can see that light is over the whole wall past the image receptor or the Bucky. We want to make sure we're collimating down to at least only the size of the Bucky, because anything outside of that is just extra. Like it's going to be nothing there. It's just additional radiation, and it actually degrades our image quality when we don't collimate. So again, collimation is really important. The smaller the beam, also the less radiation dose that your patient is going to receive. However, we don't want to collimate too small to where that we're cutting things out that need to be there. Another thing, again, with the collimation, it does prevent what we call scatter radiation. That's the first way that we control it. Outside of a grid, we control it with collimation. Scatter radiation, if it does get on the image, if too much gets on the image, it causes fog. And just like when we're driving, fog makes it difficult to see. For X-rays, it puts additional contrast or shades of gray on the image and makes it difficult for the doctor or us to see what we need. And like Lacey said, it shows us exactly what is going to be exposed. So whatever's in the light is what is going to be exposed, unless, of course, like we said, we're not detinted properly. It can be operated manually or automatically. So we have something called a PBL, positive beam limitation. At one time, it was mandated by law that all machines had that, but now it's not necessarily mandated, and it's a feature that we can turn off. So there's a key in the back of the machine. So back in the day, I'll say back in the day, when we put an image receptor in the Bucky, whatever size that image receptor was, the PBL would automatically shrink the collimation size to that size of the cassette. And again, you could turn that feature off, but that's what we mean by automatic. You don't have to turn those dials with your hand. Automatically, once you put that cassette in the Bucky, it would slim down to whatever the size of that cassette is, which was usually 8 by 10, 10 by 12, and 14 by 17. Those were I think we had an 11 by 14 too, but that wasn't like one that we used a lot. All right, so that is definitely what the collimator is for, so I can agree with that. All right, next we have our radiographic table. All right, may be fixed or variable height, meaning fixed, meaning I can't change the height of it. typically has a four-way float, so I'm able to move the table or float it towards the feet, towards the head, left or right, versus having the patient, hey, can you scoot down towards this way? Can you scoot up towards this way? Can you move over there? Can you move over here? I can unlock the table and move the patient versus having them, make those type of movements. Now, of course, if you need them to roll over, they have to do it. But if we need to move them up or down, we can move the table. Highly radiolucent, meaning the x-rays go through it and the table doesn't show up on our image. And some table designs permit variable speed and tilting capabilities. So depending on the type. So fixed tables are typically in our rad floral rooms. So those rooms that have the capability of not only doing x-rays, if we wanted to just do x-rays there, but also do those fluoro exams. Underneath those tables, there is an x-ray tube. So therefore we can't move the table up and down because we need it to stay exactly where it is. Also, those tables allow for tilting. So we can tilt the patient Trendelenburg. Anybody remember what that term means? Going back to probably a medical terminology class. Trendelenburg. All right, so we're tilting them down towards their head, so head down. And then with those tables, we can also stand the patient up. So we would have a footboard. We would make sure that their feet were in contact with the board, and we can take the patient from laying down to standing. They don't have to stand up. We stand them up with the table controls. And that's some of the things that we need to move the contrast in those fluoro studies. And then the regular x-ray rooms, we can move those tables up and down, meaning I can lower it so that the patient can get on the table easily, and then I raise it back up to the working height. Typically, the height is indicated by some sort of light. We'll raise it back up until the light is there. Also, you wouldn't want to spend your day just bending over the table all day, so that makes sense, right? To raise it up to a working height so you're not straining your back, especially if you're doing this for 8 to 12 hours a day. So those are your regular rooms. And I think, for the fixed rooms, we don't just have our patients figure out how to jump up on the table. Some of them have like a foot, I'll say shelf that we can pull out or push back in. And then some of those rooms, we have to have a like a external step stool to help or assist the patient with getting up on the table. All right, and this one is just going into what a tilting table actually does for us. Again, those are in the rad floral rooms. It permits us to tilt the table from horizontal, meaning flat, to vertical, meaning we've now stood the patient up, and then we can tilt them head down in the Trendelenburg position. Most of the tables have the four-way float, meaning I can move them towards their head, towards their feet, to the left or to the right. And tables typically do not have variable height capabilities, meaning this rad fluoro table, I can't move it in terms of up and down. It's fixed. So in order to get the patient on the table, if they need assistance, I need some sort of step stool mechanism. All right, next is our Bucky assembly. So Hayden, you are the last one. What does Bucky assembly, what did you get from your readings about Bucky assembly?
Sorry, I ran to the restroom. What was the question?
What did you get from your readings about the Bucky assembly? What do you think the Bucky assembly is?
It holds the image.
Okay. When you say holds the image, you mean
Like takes the picture. Yeah.
um okay, so it basically is the place where we put the cassette in if we're doing any type of Bucky work, meaning they're on the table and we're pulling that tray out that we need to detent, or they're standing up against that upright Bucky. Those are called Bucky assemblies. So that is where I don't know if you ever paid attention when there's a button on virtual medical coaching where you have to make sure that there's a cassette in there. All right, so it holds that cassette in place. Also in the Bucky assembly, we have what we call a Potter Bucky grid. Grids is the second thing that helps us clean up scatter. And those grids actually move, or they oscillate during the exposure. So they kind of move back and forth. And what happens, let's say you're taking a picture of, you don't have a high speed camera. So let's say back in the day camera, you took a picture of someone and they happened to move. What might you have noticed in that image?
It's blurry.
All right, blurriness. But in this case, we're wanting to blur out what we call grid lines. We don't want the grid lines to be seen. So as the Bucky is isolating or moving, the x-rays are still going through the grid where it needs to get, but now we're not seeing the grid lines because we're blurring them out. So every Bucky assembly has a Potter Bucky grid in it, but the main goal of it is to hold that cassette in place. Can be used with all of our image receptors, whether it's CR or DR, and back in the day, even our film screen cassettes, all of them would fit into a Bucky assembly. So as Hayden stated, it holds the image receptor. All right, next is our generator control. I'm just gonna say for me, this just is like our control console. There is another piece of equipment in the room. It typically looks like a box that holds the other pieces to this, but our generator, X-ray generator, is basically our control console. All right, it's where we interface to ensure that we've set the appropriate technique for the patient's exam. So we're changing the mass, we're changing the KVP. We have the option to use the automatic exposure control, which is a piece of automation that assists us with the timing piece. We do have to have an MA station that's appropriate, but the AEC actually trips the timer and stops the exposure when its detectors tell the system that it's received enough exit radiation from the patient. You can have anatomical programs there. So if you're looking at your control console and you see either a picture of whatever you're trying to x-ray or the words, maybe it's a skull or maybe it says head, that's your anatomical programs. In my opinion, these anatomical programs replace what we called a technique chart. A technique chart used to be required to be in every room. It was just baseline exposures for every exam. So if I was a new technologist and I came on board, I didn't have to ask anybody, oh, what do you think a good technique for this is? I could just look at the technique chart and that gives me the baseline exposure for what we call the average male patient. Now, these numbers that pop up, just like in the simulator, they don't have to stay. I mean, if the machine is calibrated, they probably are going to work for the average male patient, but we're not going to use the same technique on an average male patient on a pediatric patient or a baby, all right, or a super duper asthenic patient. So those are numbers that we can change based on what we know. So when you go out to the field, you're really not going to know anything. You really start off as just a button pusher. But after you gain a little bit of knowledge and you know what mass does for you and you know what KVP does for you, you need to be able to critically think. If your image comes out grainy or mottled, oh, what do I need to do on the repeat? All right, I need to increase the technique. So even though the numbers pop up, those baseline numbers pop up, in some cases, if it's not calibrated, they might not work, and they don't have to stay those numbers. You can change those numbers just like you see in the simulator. Your generator itself, you can consider it like a microprocessor, like a small computer, with a very simple interface. Again, it might have pictures or wording or numbers that you can easily adjust. Again, allows you to select the MA or the time independently, or you can change it as one number, meaning the mass. It allows you to select the KVP for the exam. So MA controls, going back to last week, can anybody tell me what MA controls? In terms of the X-ray beam itself, what does the MA control?
Isn't it the milliamperes per second per time?
What does it control? Okay, yeah, it does control the time that the exposure is on, but it also controls one other thing.
The total number.
Total number of X-ray photons that are in that beam and the time that the beam will be on. All right, not you, Shelby. Anybody else? Can you tell me what KVP controls? Kilovoltage peak, what does that control?
Doesn't it have an effect on the graininess or the clarity of the image?
It can, but mass can control that too. KVP controls,
Does
so if
it
you go back,
control the power of the beam?
yeah, the power. If you go back to those Bontrager pages, each exam, based on the body part, it gives you a range, a KVP range. So the KVP controls whether or not
Could it
that
be
particular,
72? Sometimes, is that where you can, the KVP, you can kind of manipulate the numbers, like the 72 or whatever
you
you're
can.
looking for, like the distance? Or is that what
So
the KVP does?
it controls, so all of these are numbers, MA and time are numbers, KVP and are numbers, but it controls what they call the quality. So MA controls the quantity or the number of X-ray photons in the beam. The more you increase it, the more X-ray photons in the beam. If you reduce it, the let's say I started with 100 and I cut it to 50. All right, I cut the number of X-ray photons that are in the beam in half. If I went to 200, then I doubled the number of X-ray photons in the beam. KVP controls whether or not that beam is going to be strong enough to penetrate that body part. So if you're looking at those number ranges in your book, if you look at what number it gives for the hand versus what number it gives for the chest. All right, chest is probably something like 110 to 125, whereas hand is something like probably 50, 55 to 65. So I need a lot less power to penetrate my thin hand versus a thick chest. So it controls whether or not that beam is going to be strong enough to penetrate that part. And your Bontrager book, when you get one, is going to give you a range of numbers that should be good enough to do that. For the average male patient, of course, you wouldn't use these same numbers again on your ped, or I'll say a regular ped, not our new peds that are like our size, on like a pediatric patient or a baby, you wouldn't use those numbers. All right, focal spot size, we have two. We have a large focal spot and we have a small focal spot. One is used for detail, which is the small one, and typically on smaller body parts. So like that we need to see a lot of detail or bony trabeculae like hands, extremities, etc. And then the large focal spot, even though we would love to use the small one on everything because we would love the most amount of detail, with that amount of heat that's being generated for that exam, we need a larger surface area on our anode for heat dissipation. So larger body parts usually trip over to the large focal spot. It's usually automated these days to where you're not selecting it based on the body part that you select. The focal spot is also kind of chosen for the machine. With our newer equipment, it's not going to allow us to put any exposure in there or any focal spot in there that could potentially damage the machine versus back in the day. And then the last two, AEC, basically a piece of automation that uses the patient body habitus as a factor to terminate the exposure once enough X-ray photons are detected and at the image receptor. And then anatomical programming, that's where you see the picture or the word of whatever body part is, you select it, and it automatically throws up those numbers in terms of mass and KVP for you. All right, and newer systems are integrated with the DR detector. So basically, the instead of having now a CR where you take the you take the image and you have to take it to a processor, we're shooting straight at the detector, and the image is basically popping up on the computer screen within seconds of the exposure. All right, so that is your control console. Every room will have a control console. All right, exposure technique. So let's go back up to the top. Well, I'll just go over this one because we kind of already went over it already. We have 3 key factors, and if one of them is combined, we would say 2. We have an MA station. We have a time that the exposure needs to be on. If we add them together, MA times second is our mass, and it controls the number of X-ray photons that are in the beam. The higher the mass, the more X-ray photons, or the more quantity. And then KVP, we already said that controls the strength of the X-ray beam, whether or not it's going to be able to penetrate that body part of interest. AEC, a piece of automation, you can use it. You can turn it on or you can turn it off. You can only use the AEC with Bucky work. Anything tabletop, you have to set a manual technique. With the AEC, we have 3 chambers or detectors where the X-ray is going to be received. We have 2 outer chambers, a left and right, and then we have a center. So again, when you're selecting some of these, again, on our smart systems, when you're selecting the body part and you say, I want to use the AEC, the smarter technology will automatically select the appropriate detectors. If the wrong detector is selected, and this is not in this lesson, but you have the potential for an overexposure or an underexposure because it's reading the radiation wrong. So if I select the chest, I want to use the AEC for the chest. If I'm selecting the center cell, it's reading the X-rays that's exiting from behind the center. And what is in the center of our body? What's in the center of your body?
Our stomach,
All the way through, like behind or between the lung fields.
our spine,
The
Kidneys.
spine. All right. So with bone, since it's radiopaque, it's harder to penetrate it. So the machine itself is trying to say, okay, I'm going to stop when enough radiation is reached. But instead of it being air-filled lungs, it's trying to detect for the center cell, which the spine is over. So that exposure is going to stay on longer than it should. And back in the day, it would have resulted in an overexposure. I mean, it is an overexposure for the patient, but it would have been a darker image. With the newer technology, sometimes it's an overexposure for the patient, but the image may still look good. But that's one of those things that you can play around in your simulator. Shoot a chest and select the Rome detectors and see what your actual image looks like. So you have to, if you're using the AEC, you have to make sure the right detector cells are on. Focal spot size, again, we have 2. What were the 2 that we talked about? Anybody can answer?
The focal size, is that what you're saying?
Focal spot size, what two,
Large or
uh-huh.
small?
All right, we have a large and small, small for detail, so the smaller parts, and then larger for larger parts needed for heat dissipation. And then of course we have the APR as well. That's just a picture of what you're interested in or the wording of what you're interested in. And when you select it, it's gonna throw up those exposure factors for you on the control panel in terms of KVP and mass. Now, if you're using the simulator in practice mode, it's going to throw it up there for you. I think if you're using it in like evaluation mode, I don't know the terminology, then I think you have to set your own technical factors. All right, exposure technique selection. All right, so again, these items are found on our control console or X-ray generator. On that console, again, you're able to select your KVP, your MA station, and your exposure time independently, or you can select in terms of the MA and exposure time, we can change just that one number, which would be the mass number. So the next time you go to your simulator, you'll be able to see that you can change just the MA. And when you change the MA, you'll see that the mass number changes, or you can change just the seconds. And when you're changing the seconds, you'll see that mass number change as well. All right, maybe operated, that's what we're talking about, maybe operated in mass or timer mode, meaning you can change the numbers independently. Like I want to put in this MA station in this time, or you can just change the one number that is under mass. All right, newer systems feature a picture or icons for the technique selection. So again, we're talking about the APR where you might see a picture of a hand or a skull, or you might see just the wording of what you're interested in. Technique selection is critical to good radiography. If your technique is too low, these days, you'll come up with that model, especially if it's grossly too low, you'll come up with that mottled, grainy, noisy image that is an automatic repeat. If it's too high, unless it's grossly too high and it causes saturation, unfortunately, sometimes you will just have dosed your patient or gave them more dose than they needed. With digital, sometimes it's still a good image. And the only way you know it was a bad technique is because we have EI numbers or exposure control numbers, sensitivity numbers. Didn't we talk about that in another lesson? I mean, we might not have talked about it, but was it in another lesson? Sensitivity exposure indicator numbers. All right, that number just tells you that for this body part, when we take the image, the number needs to pop up in this range. If it's out of range, either below or above, depending on the system, that means you overexposed or underexposed the patient. But with digital, it doesn't necessarily mean that the image is going to be bad unless we've grossly underexposed, which means that image will look grainy and it is a repeat. Let's see. And the automatic repeat will show quantum model. Another term is quantum noise, and that's that grainy image. So there's no amount of what we call post-processing, where you have that window width and window level where you can change the brightness or the contrast, the things that you can do in your simulator. There's no amount of that you can do to get rid of that graininess. It's going to be there. It is an automatic repeat, and it tells you that the technique that you chose was too low. All right, X-ray tube support. All right, we had 2 basic designs. So going back up to the top. Dylan, what were the two designs that you learned about in terms of tube supports?
Second. Trying to remember.
So if I need to support you, that means that I'm doing what?
You're doing something to help carry or just support the weight or the term of the
Okay.
X-ray. So the X-ray tube supports would be something in terms of like supporting the tube itself, whether it be something to hold it, keep it
Mhm.
up, and
And we
maybe
talked about your book talked about two designs.
I'm trying to think of them.
Anybody remember?
Is it to hold yourself?
It does hold the tube, but your book talked about two designs that you might see out in the field.
No, like the patient to hold, like the patient could hold into the tube support?
Oh, no,
No,
no.
okay.
All right, the two designs before I put you here on break in a second, we have the overhead tube support, and then we have the floor mounted tube support. So with the floor mounted, it's bolted to the floor and the tube just traverses along the side of the table. So it's less versatile in terms of how we can move it around the room because it's stuck right there on that rail. The other one is the overhead tube support or tube mount. And there we have rails in the ceiling of the rooms, the most versatile, probably the one that you'll see in most hospitals and most modern imaging centers. And it just allows you to move the tube basically all over the room along the rail. So it gives you a little bit more flexibility when it comes to positioning the tube, especially if we need to do things like a cross table lateral, or maybe I have the patient sitting in a chair over here because maybe it will be too difficult for me to get them on the table to do their foot. So I can put them on the chair and I can bring that tube way over there and I can lower it down to the floor and put the cassette on the floor. So it gives us a lot more versatility than the floor mounted one. So the X-ray tube assembly basically allows us to move that tube or maneuver that tube all around the patient based on how we need it to be for that patient exam. Ergonomically friendly, meaning they're very easy to move for you as the tech. And then I'm not sure why they say aesthetically pleasing, not intimidating for patients, but I mean, it's just basically what holds our X-ray tube and allows us to move it. So it is now about to be 9 o'clock. So on your header, I need for you to place ICA 7, 11, 14, 859. And then the title is Medical Imaging Equipment. Go ahead and load that for me, and I will see you back at
You said ICA
9,
7 what?
And what
No.
is it? Oh, I'm sorry.
11, 14,
Mhm.
859.
And then we upload that now, or we just upload it at
And
the
you
end?
said medical, say that one more time?
Medical imaging equipment. Go ahead and upload it now so that I can note who was present at this moment. And then I'll see you at 9:10.
Do we upload everything that we have now, or just this one paper that says
You can
that?
just do the front page for me.
We don't have the ICA 7,
Yeah, you're right. You're right. You don't.
and I accidentally uploaded it to the ICA 9.
Okay. 7. I see 7. All right. When you refresh at the end of class, you should see it in module 8. And I am going to, where is ICA 9? I don't see an ICA 9.
I have it on mine.
In what week is it in?
I just went to,
You have it? Because I don't have it either.
I have ICA 9. I didn't have ICA 7, but I just went to
Oh,
grade and scrolled down at the
that
very
might be in, but you don't have that assignment
Updated it,
still.
and ICA 7's there now for me, so.
Yeah, ICA 7's there now for me too, but I have ICA 9. I don't know. See?
Okay, I
I don't
got
know
it.
if you can see, but
Yeah, I don't know where there is one, but it's not in any of the modules yet. So I'm gonna go ahead and hide that. It's more so in assignments, and I didn't think that y'all had that tab. I can't hide it because you put something in there, but that's fine.
I can delete it. It's okay.
Okay.
Just give me 1 second. I'll delete it. Oh,
Right,
it says
so
access denied. So,
that's fine. I unpublished it.
okay.
So,
Okay, I got it. Thank you.
All right, all right, moving on. So we stopped at our tube support. We said there were 2 different types of tube support. And your book has pictures, but one of them is your overhead. Again, the rails are in the ceiling, and the other ones are they have a floor mount and a floor to ceiling mount, but in both cases, they do traverse around just a track that is along the side of the table. So when you're trying to move the tube around, there's not a lot of flexibility in where you can actually move it. It's not, you can't move it all over like you can do the overhead one. All right, and then there's one that actually kind of shows you like the motions and how you can move it, but I don't have those on my screen. All right, user friendly. All right, user friendly. So the newer, and this picture is in your book, the newer overhead model designs, they actually, like back in the day, we only really had just the collimations and then the collimation knobs and of course the buttons to rotate and swivel, move it up and down, and then of course the SID. But the newer ones have the controls there as well. So you can go ahead and set and see the MA station, the time, the KVP, etc. And there's a picture in your book where it shows you that. And of course, it has a flat panel screen, just like that's easy to manipulate, just like your X-ray console. And it also holds your last image for you. So the last image, you can, on some of these, see it. And you can easily start your manipulations. Like if you say, okay, I cut off the distal part, so I need to move my patient up a little bit so I can get the distal part. And then it allows auto tracking. I don't like auto tracking, and I don't think it's a feature that new students learning should use. But auto tracking means that when I move one part, the other part follows. So if I move the bucky, the tube on its own is going to follow and automatically, detent in place. Um, and I just don't like it, just I guess because I'm old school and I didn't learn on it. And, older people don't like to learn newer technology, but the newer machines a lot of them do have the auto tracking. And then also, still, the exposures do require you to stand behind that window. If you're the only one in the room and the only one that can push the button, of course, you need to be behind the window. And in fact, some of the newer technology, you can even do some of the positioning of the tube and all of the collimation from behind in the control booth too. But it just depends on what your company, or facility has invested in. All right, upright bucky assembly, is just showing you a picture. This is basically your chest bucky or your wall bucky. The only thing you can do for this is adjust for the height. It's bolted in the floor. You can't move it left or right. You adjust for the height and ensure that you are detented, in terms of the side to side with the tube. And again, you can use it at 40 or 72 inches. 40 inches, usually everything except for chest. And then lateral C-spine is chest and lateral C-spine are 72 inches. And then your oblique C-spines, you can do 40 or 72 based on, whatever the protocol is or what you like to see. With the 72 inches, there's a little bit less magnification there. All right, next are our image receptors. This is something that we touched on last week, I believe. Your image receptors, no matter which type, their job is to intercept that remnant radiation, which is the exit radiation that's leaving the patient. And eventually, as it captures that radiation, eventually it will be changed into an electronic signal that will be representative of your manifest image that's on that computer screen. Most systems now, especially if it makes sense, everybody's probably gone to the DR, which is it does show up, whether it's CR or DR, it does still show up on the computer screen and you can manipulate it post-processing, but DR is a little bit quicker because that CR technology is still cassette based in the sense that to get that image, you have to put it in a processor. With your DR, most of them are going to be your flat panel detector technology. It has these TFTs in them that are going to collect the electronic signal and eventually be converted into that digital signal that creates that image that are on your computer screen. So in terms of your TFT systems, they can be direct or indirect. Last week we learned about these. Indirect means there's some sort of scintillation material, meaning that the X-rays first will be turned to light, then eventually converted to that electronic signal, whereas your direct technology, the X-rays will be captured and converted directly into that electronic signal. So CR is still digital, but it's not as efficient and as fast as our DR technology. All right, so important to remember. All right, so we're talking about the remnant radiation or the exit radiation. Although a few weeks ago we learned about different types of radiation, like primary radiation, etc. For image creation or image formation, what's really important is that remnant or exit radiation. It will exit the patient, interact and be absorbed with whichever type of detector you have, whether it's CR, whether it's DR. Eventually, the information that's captured will be turned into an electrical signal that is then turned into the digital data that's representative of the image that's on your computer screen. Now, there is another radiation that is potentially exiting, and that is scatter radiation. All right, scatter radiation doesn't add any additional diagnostic value to your images. In fact, you need to control it. The first way we control it is collimation. If it's Bucky work, the second way we control it is a grid. But in any case, scatter radiation, if not controlled, it actually degrades your images by putting that additional contrast or fog on the image that makes it more difficult to see. So we always want to make sure that we are collimating, and if the image can stand a grid, we want to use a grid. So that would be like anything a near or larger, and anything Bucky work. And of course, if we're using a grid, which this is not in this lesson, we want to use the lowest ratio grid, because the higher the grid ratio, the more technique you need. And of course, with a higher technique, you're increasing your patient's dose. All right, in terms of our DR technology, our modern DR panels, they can be wireless or they can be tethered, meaning they're on a cord. Most of them, the wireless ones, do have a battery pack, and the batteries do need to be charged. So hopefully your facility has a couple battery packs. If it is your only DR panel and it dies, of course you're out of commission until you get it charged again. All right, those DR panels contain DELs or detector elements, and those detector elements basically capture that exit radiation or that remnant radiation, and they will eventually convert that information into an electrical signal, and that electrical signal will eventually be change into digital data that the computer can understand and present as the image that we see based on algorithms or data sets that are saved in the computer. So it tries to pre-process it in a manner to where it looks the best. Now we can always change what it looks like, but it tries to present the best possible image based on the technique we chose and the information it has based on that remnant radiation received. All right, your DR panels are more dose efficient. So with the newer technology, when we say dose efficient, it is able to detect really low levels of radiation and also really high levels of radiation. They are very expensive, and they are sensitive to mechanical shock, meaning they are sensitive to drop. So if we're dropping our cassettes, not only does it record it, meaning it records that time and space where the drop happened, the time and the date, and that can be retrieved, especially if the cassette is actually damaged, and we can kind of figure out, oh, who was working during that time to kind of narrow it down to who might have damaged it. They are sensitive to fluid invasion, so if you're going on any portable exams or you're bringing someone in the room where there's a potential for it to get wet based on blood or some sort of fluid, we want to make sure that we're putting them in the appropriate bags to protect the equipment or the detector, because it's very expensive. They are just like any other cassette. Grids are important to clean up the scatter. And of course, now it is opening up to newer imaging technologies like TOMO, whether the TOMO is in X-ray, which is pretty much obsolete, or mammo. And then also dual energy subtraction, which is basically kind of like on the CR, not CR, on the C-arm type technology or fluoro technology where I can take an image and I can, if I'm only interested in the vessels, let's say I shot some contrast up or I'm doing live fluoro and I want to see where maybe a blockage is, I can subtract out all of the information, just like the new technology with the cameras. You take a picture in the background, there's something you don't want there, you click on it and it takes it out. This is what that dual energy subtraction is. It's taking out all of the, let's say if I'm interested in vessels, I don't want to see any bone there. So it subtracts out the bone for us. Now it doesn't get rid of it. It still saves that original image, but it also saves the subtracted image, the only the vessels as well. All right, next we are moving on to fluoro. So regular X-ray, we call it static imaging. So it's just a picture in that moment. And fluoro, I think we already talked about it on a previous slide when we first started. We call that dynamic imaging. So we're basically talking about live X-ray. We're able to see the function. So if the patient waves their hand in the beam, then we'll see that their hand is waved in the beam. If we're trying to place a needle and inject, we can see that the needle, where the needle is actually going. And then when we push the injection, we can actually see where the injection is going. So fluoro gives us those real-time images. Really good for functional studies. And when I say functional studies, things like our swallow studies, they're good in, interventional cases. Maybe we're looking for a bleed that we need to block, or maybe we're looking for a blockage. They are good for fluoro. Your OR cases, and then also, let's see, I think that's probably about all. Anything functional. Equipment designs feature an X-ray tube with an attached image receptor in a perpendicular relationship. So with our fluoro units, whether it's a rad fluoro unit or whether it is a C-arm, it also has some sort of image receptor detector or image intensifier, or a DR panel is where we're going with the newer technology. Fluoro equipment can be fixed or mobile. Fixed is our rad fluoro room, is bolted to the floor. Mobile is our C-arm units, where we're able to move it to wherever we want it, whether it's a pain management suite, whether it's an OR suite, we can move it to the patient's bedside. All right, your rad fluoro units, not only are they capable of that live feature, we can also take those spot or 2D images with it. Meaning I can just take a regular picture, or I can have that live feed or live video going where the X-ray is constant. Your complete fluoro unit consists of that rad fluoro table, the one that does not lower, but it does tilt, Trendelenburg versus standing up vertical. You will have an image receptor available. It has an X-ray generator and controls. It does have a ceiling mounted X-ray tube. Typically, if we're using fluoro, we're going to move that tube out of the way. We typically push it in a corner of the room because it is on that ceiling track. We can push it out of the way. And then we will need a video display monitor. Everything that happens in fluoro does show up on a video monitor that is usually placed in a position where the radiologist or whomever is doing that exam, speech pathologist, can actually see what's going on with the function of that patient in real time as they're actually performing the exam. The controls for the table are on the side of the table, and they're also on the fluoro tower as well. So you can move the table, you can change the mass, you can change the KVP, all at the table side. All right, your rad fluoro table, the image receptor itself is considered the primary barrier, meaning that is where the X-rays are going to intercept. The tube, again, with most configurations these days is going to be underneath the table. So the X-rays will intercept the patient from the rear if the patient is laying on their back, and it will exit out of the patient and intercept at the fluoro tower, which has the image intensifier in it. All right, or the newer technology is your flat panel detector instead of an image intensifier. On the fluoro tower as well, we have a curtain or a drape that is made of lead. The purpose of the curtain is to protect, of course, the radiologist and the tech that are standing right there close and up in person with the patient from that scatter radiation. But a lot of times you'll see with the radiologists in these cases, I guess they feel like this curtain is in the way. So they do actually remove it and put it out of the way, but it is actually a protection for them to help with the scatter. Now they have on or should have on a lead vest, but this is just an additional piece of protective equipment for us, which is attached to, or we can attach it to the fluoro tower, to continue to reduce our occupational dose. All right, our modern fluoro units or rad fluoro units, we do have what we call a high frequency generator, so very efficient pulse generator. It usually or can have that flat panel detector versus the image intensifier. They are capable of last image hold, meaning after I take an image, it holds the very last one. And if we're talking about, let's say we're talking about a C-arm, we usually have two monitors, well, C-arm and fluoro room. We usually have two monitors. So the last image, once I start a new image, will flip to the second screen so that the radiologist or whomever is looking at it can see it. So it does hold the very last image that we took. Pulse progressive fluoro. So instead of it being constantly on, it does like a pulse, like beep, beep, beep. So it looks like it's constantly on, but there is a little bit of pause, and that pulse progressive fluoro kind of helps with the patient dose, especially in our longer cases. And then we have dose modulation. So we can change the exposure factors if we need to, and that helps with keeping the patient's dose as low as possible. Again, with fluoro, these are very, and so with just x-ray, you hear it beep and we have an image. With fluoro, they're under radiation for a longer period of time for that exam. So it's not just a beep. It's as long as the radiologist wants that fluoro to be on, or as long as the surgeon wants that fluoro to be on. All right, and this was just a picture of your tilting table. You can look in your book for that. These are just images. All right, C-arms. So C-arms, they can be used, we call it a piece of interventional technology, but it is capable of fluoro. It's also capable of just taking a still static image as well. This has a use for interventional procedures. So interventional procedures and just regular procedures like surgery. Features a C-arm design, and we talk about a C-arm design just like the wording. If I can write on here. All right, just like the wording. Ooh. It looks like a C, and the patient is in the middle of the C. I don't know, it keeps doing that. All right, so when the C looks like this, we're doing more so anterior to posterior if the patient is on their back imaging, or posterior to anterior imaging. I'm sorry, back up. Posterior to anterior imaging if the patient is on their back, because remember the X-ray tube is underneath, and anterior to posterior imaging if the patient is laying on their stomach. Now, to get the lateral images, we would need to turn the C to where it looks like this, and the patient is in the center. So now we're coming in from, the x-rays are coming in from the side of the patient. So we call it a C arm because it just looks like a C. But again, it's capable of fluoro, and it's also capable of regular static images. So the newer systems, instead of having the image intensifier, they're using the flat panel detectors. Image intensifier is a piece of technology that they came out with to brighten those fluoro images. Back in the day, with fluoro, the radiologist had to do something called dark light adapting because the images were so dim. So they would put on red goggles and sit like in a very dim room for a period of time so that they could see those dim images better. But now with the image intensifiers and even the flat panel detector, they no longer need that. All right, mobile X-ray imaging. I felt like I asked this question already, but I think that was in the other class. So going back to the top of my list, let's go with Dylan. What does a mobile unit mean to you based on your readings and your research?
Is a unit that allows to move around different places other than being stuck into one, certain area. So you can see a lot of them places like emergency rooms and stuff where they have to go from room to room,
Mhm.
or in just different situations where they need to travel and gives more mobility to the unit.
Okay. So just like Dylan stated, our mobile units, sometimes we call them portable units. They are on wheels. The C-arm is also considered a mobile unit, but in most cases, when we're talking about mobile radiography, we're just talking about the portables. So we've made a decision that it will be better to take this unit to the patient's bedside versus bringing that patient to us. So that might be the patient's condition. Um, maybe they're unstable ICU patient, or maybe, it's an ER case where they just came in as a trauma patient. Maybe they're in isolation protocol. Maybe they're, a pediatric patient that might be in NICU or PACU, to where it's better for us to go to the patient versus the patient coming to us in the regular X-ray suite. The exposure control itself, meaning in order to make the exposure, it is on a flexible cord. That cord is typically able to move out to about 6 feet. So when you're taking this, after you set everything up, you want to move in the opposite direction of the X-ray tube, away from it, about 6 feet before you make the exposure. So time, distance, and shielding for us, that means we're getting more distance. So for our occupational dose, the more distance we can put in between us and the source, the less dose that we receive. The mobile units or the portables, the newer ones, they are a lot easier to move. So when you pull on the handle to push it, sometimes it kind of almost drives itself, and you just guide it to where it needs to go. So they are a little bit more motorized than they were from the older versions. All right, they are capable again of they have the same capabilities of our fixed X-ray units. And if we're talking about the fluoro piece, has the same capability of the fluoro unit as well. Specifically the C-arm, it just happens to be on wheels, and it can do regular static X-rays and also fluoro. They are pretty compact or small. We push them up in a little corner of the room, very user friendly, kind of like your cell phone with just little, like a flat screen that you're just selecting options. Limited power for some of the studies, so um limited power because some of the ranges in terms of kVp and mass, we might not be able to get that on some of the portable units. Again, commonly we call them portable because we can transport them to the patient versus the patient coming to us. They should be plugged in when they're not in use. Nothing like getting a portable up to a unit and you need to do a few x-rays and it dies and you have to come back. Hopefully you have another one, but if it's the only one, that means it's got to be charged before you can finish your job. And the newer systems use a wireless portable DR detector. So basically, kind of like a cassette, but once we take the x-ray, the images are actually showing up on the actual portable machine. You can see right away if it's a repeat or not. And then of course you can send that information on to the PAC system once you're done with it and then move on to your next patient. Back in the day, we would have to take all these cassettes, take our images. Hopefully we don't mix anything up. Then we would have to come back to the radiology department or wherever that stage place was in the hospital. If it was CR, then we would see if it was a repeat or not. And then we would have to go back. Now it's, we see what we need before we leave. We don't leave before we get it right. All right, mobile fluoro, we're talking about the C-arms here. Those are used, of course. I wouldn't say they're really used in the ER. They definitely are used in the surgical suites. They're used in pain management. They're used in no, they're not using the interventional suites because they have their own. Again, it's called a C-arm because they look like a C and they have a fixed SID and they are centered to the X-ray tube. So at the tip of the C, we have the image intensifier at the top or the flat panel detector at the top, and then the X-ray tube is at the bottom. We can't change the distance between the two. It is designed and fixed in that way. So we have to use it as is. All right, newer systems, again, they say we're using those flat panel detectors versus the image intensifiers. We do have mini C-arms. They're good for smaller body parts, but they do have limited power because we're only using them for things like extremities. These mini C-arms usually aren't owned by the radiology department. If you're in charge of radiology department and you're responsible for purchasing the equipment, typically a mini C-arm is not something that we would purchase because it's limited. You can't use it for everything. So the mini C-arms are usually owned by or purchased by the ortho departments. And in some cases, they teach their ortho techs to run those mini C-arms as well. All right, the components of the C-arm, you have a generator, you have the C-arm. It does have a mobile onboard computer, and then also you have some type of monitor system to show you the two, like the last hold image and also your image that you're doing, whether it's just still image, meaning a spot film, or whether it's, live fluoro. The reason why we have the onboard computer is because we need to pull up the patient's information and exam. And so that everything can be tagged in that exam with the right patient information. All right, digital tomo uses a flat panel detector. We acquire images in a single sweep. So instead of, our x-ray unit, we're usually perpendicular to the patient. Digital tomo has an arm that we attach to the x-ray unit, and the arm allows, let me see if I can see where's our pictures at? I can't see our pictures. I don't know, hopefully you can see my hand. I can't find our pictures, but the arm allows the tube to kind of sweep over the patient in like an arc or a rainbow. And at the point to where we're at the center of the arc where the tube is perpendicular, that is the only piece of anatomy that will be in full vision. Everything above and below that point will be blurred out. And again, Tomo, in terms of regular diagnostic, it's being pretty much phased out. You might see Tomo in Mammo now, and then of course that is what CT is. So all of the Tomo that we used to do in X-ray, we now send those to CT. So it was usually things like IVP or IVU, which is like looking for slices of a kidney or kidney function. So again, Tomo is pretty much obsolete in diagnostic, but you do see it now in breast imaging. And then also, our CT images, of course, give us slices. And the reason why we're interested in it in breast imaging is because we're looking for very small lesions and microcalcification. So if we can get down to a certain cut or slice, we might be able to see it a little bit better. They don't want to miss anything because the faster or earlier you can detect that lesion or tumor, the better the patient's prognosis because you can start treatment earlier. As we stated earlier, dual energy subtraction, this is a piece of technology that we can use to subtract out information that we're not interested in so that we're only looking at the information that we want to see, like the vessels, contrast filled vessels. Again, it's not that the information is no longer available when we subtract it out. We still have the original image, but it does allow us to see only what we're interested in and getting that anatomy that might cover or obscure what we're interested in out of the way. All right, CT. Some of you might be interested in going into CT after X-ray school and after you pass your boards. Again, it takes the body and we can slice it into slices like a piece of bread. We can slice you from front to back and we can slice you from top to bottom. And then we can go down or drill down to the individual slice where the issue is. The CT machines, they have a CT gantry. That is that donut looking thing that you see. They have a patient couch, which is the table that the patient lies on. And then of course they have a more sophisticated operating console and computer, maybe a couple screens, and they're capable of, once they get those slices, they can build 3D images that, or reconstruct 3D images that might be needed for planning, treatment planning, or some type of surgery. So this is a modality that you might be interested in after X-ray school. All right, CT exams, we can do contrast or non-contrast, which is considered enhanced if it has contrast, or unenhanced if we don't have contrast. The patient can go in on the table head first. They can go into the gantry head first or feet first, depending on what you're interested in for that exam. Some patients don't do well in terms of claustrophobia with CT imaging and also MRI imaging going into those bores. The patient couch is the table that allows the machine to move, and that machine will move on its own. Once you push the button for the exam to start, it will, you can say instructions, it'll allow you to do that, but there are some recorded instructions. It'll tell the patient to don't move, hold their breath, whatever it needs the patient to do. Because of course you don't want that motion there either. Radiation dosages are continually being improved, just like with all X-ray technology. You're able to use less dose based on the new designs and the beam filtration that they have. Again, better techniques in terms of how they can reconstruct those images into that 3D model. And then dose modulation, you can change the dose or change the techniques to allow for lower dose as well with your CT machines. All right, the next type of equipment or the next type of modality that you could go into if you were interested is DEXA, dual emission X-ray absorptometry. Some abbreviated DXA, some abbreviated DEXA, but it's used to assess the patient's bone density. So does the patient have osteoporosis? Are they borderline osteoporosis? And also, what is their fracture risk? So when we put the patient on the table, we kind of block their feet in as if they were going to get a hip x-ray. So their like toes are pointing towards each other, and we strap it in just so they don't have to hold the position. And then the machine kind of gets an x-ray or gets measurements of the patient's spine and hips, because that's where most of the fractures can happen once you do have osteoporosis. You as the operator, you sit at the console right beside the table. So very, very low dose. When I learned how to do it at probably how many years ago? Over 20 some years ago, when it was new, we didn't even have, there was no like shielding there. So they say it's very low dose, so there was no shielding. Again, the patient's spine and hips are scanned. It is painless. There is no contrast. It gives you like a paper printout of the different values, and it calculates the bone density, and it gives you a T-score and a Z-score. One of the scores is whatever your measurements were or calculations were based on an average healthy young person, and the other score is your risk fracture or measurements based on people within your age group. So those scores determine whether you have osteoporosis, whether you have normal bone density, or whether you are borderline osteoporosis. All right, next is mammo. Some of you may want to go into mammo after x-ray school as well. Not something, even though males can go to mammo school, not something that I would recommend for a male patient, because a lot of patients don't want males. And then a lot of times when you're imaging females, especially in procedures like this, or the more invasive ones, like let's say a HSG, you need a chaperone. So why would I hire a male tech if I'm always going to need that additional person there? That's why I say it's not a great field for males. In terms of looking at breast tissue, we can do screening studies and then diagnostic studies. Screening is just like your annual study for patients once they get a certain age. Although, if you have like a history of breast cancer, that age might be significantly earlier for some people. And then we have a diagnostic study. That's where they see something and they're like, okay, we need additional images. So again, we're looking for cancer in the breast tissue. The images that you get from mammo are very high quality. They have a lot of spatial resolution. So we're talking about detail because we're looking for microcalcifications and small lesions. We want to catch it as early as possible. Typically, you're going to have 2 to 3 projections per breast. And all of the machines have breast compression that is required. So this is just like a plate that you put the breast tissue in there and it clamps down on it to flatten it out, as much as possible, like a pancake. And compression is important because we want to get it the same thickness relatively all the way across the breast tissue. Very highly restricted by MQSA, which is a federal law that basically governs all of the mammo departments and mammo equipment, mammo imaging. All right. Last mammo slide. Again, the mammo units are dedicated X-ray units, dedicated only to mammograms, which males and females can get mammograms. They, just like the X-ray, regular X-ray system, they have focal spots. They have AEC exposures where you can get the machine to assist you with the timing of it all. Their target material is not tungsten, it's usually molybdenum and rhodium. They do have the rotating anode as well. Very low kVp, and the reason for that is we're only shooting through soft tissue, so we don't need as much power to penetrate that. But they do have higher doses in terms of mass. They also can have the DR detectors. They are a magnification type study, and with magnification comes higher dose in that particular area because we're kind of honing in on a specific area, trying to look at those microcalcifications if there are any, and also lesions. All right, breast tomo, meaning taking slices of the breast tissue so that we can see every level of it, or several levels of it is becoming the standard. And the reason for that is it's going to allow them to catch it earlier than and not miss anything, because there is a potential for you to miss something, especially with like the denser breast tissues. All right, the next modality that you might be interested in, although this is not the typical pathway, is sonography. Sonography does not use radiation. It uses sound waves to produce those images. It is non-ionizing because again, they're using sound, not radiation. So it relies on a watery tissue, and then also with ultrasound, when you do it, they usually put that liquid on on the body part and the transducer to kind of act as that medium for you. Excellent for things like looking for cystic type tissues or solid tissues, vessels, of course, baby growth or fetal growth. There's a lot of things that you can look at with ultrasound. Um, and that, so it uses the sound wave to create the image. And that is really all the time that we have for this. So I will finish recording this and post it, although I think there's one there, but I'll finish recording this and post it for you all. So go ahead and load up the rest of your notes for today. So starting with the terms in terms of efficacy and uh, what was the other term? I can't think of the two terms that we started with. And then ending with medical sonography. Any questions for me?
I'm not done taking my notes. Do we have until 11:59 to post them? It shouldn't take me that long. I just need to finish them.
From the beginning to medical sonography?
Yes.
Oh, okay. Um, yeah, I'll give you until 11:59.
Okay.
All right. Any more questions?
I do, but maybe it will be like a personal question.
Okay, let me pause the recording because I'm gonna finish this up. So give me a second. All right, if no one else. All right, so our ultrasound machines, just like our portable units in X-ray, they are on wheels. They're considered mobile and portable, so they can, even though some of them are just staged in a room, they can always move them wherever they need them to go, and they can go to the patient's bedside as well. So if they needed to go to the ER, ICU, or a different clinic or floor, they can do the same thing, just like we can do with our C-arms or our mobile units. Which makes it very convenient, very flexible in terms of where you can bring you can bring that machine. Your ultrasound machines themselves, they can work in different modes, and of course, you have to be a little bit more proficient than me to understand these, but it can work in what they call A mode or amplitude mode that shows you um, some simple spikes. This mode or A mode is, they say it's not really used today, so it's one of the more obsolete ones. It can operate in B mode or brightness mode, which is that standard mode that they use to create those gray images that they see, the 2D images. They have an M mode or motion mode that shows movement over time. A lot of times they use that mode with heart valves, and then they can use it in Doppler mode as well, which can show them the blood flow and also the direction, and also the Doppler allows them to use different color and also waveforms as well. So with their machines, they do use transducers, or some people call them probes, which are basically handheld devices that are used to send and receive those sound waves to create their images. They contain what they call crystals, piezoelectric crystals that kind of vibrate to create the sound that's needed to create those images. And their probes come in different shapes, and they come in different frequencies depending on the type of exam that they're needed for, whether it's an abdomen, whether it's an OB, whether it's vascular. The probes come in different shapes. A lot of their exams will need acoustic gel, so gel that's placed between the probe and the skin, and it helps remove air bubbles, and it also allows the sound to travel into the patient's body smoothly. So the acoustic gel is needed. Sometimes it's cold, sometimes they're nice enough to have warmer. So when they put it on your body, it's not, that shock and awe effect because it's cold. So again, just like our portable machines in X-ray, the ultrasound machines are portable as well. They can operate in different modes, and also they can create their images using sound waves instead of X-rays. All right, with sonography, again, it can be, or ultrasound, it can be used in different medical specialties. So if you become a sonography tech, you can specialize as well. A lot of people want to be general techs, so they want to work in OB so that, or GYN, so that they can, look at babies all day. So looking at pregnant patients, looking at the uterus, looking at the ovaries, etc. Some patients want to work in echo or be echo techs, work in cardiography or cardiac, where they're looking at the heart function. Some people want to specialize in vascular, where they're looking more so at blood flow in the veins and the arteries as well. And then some techs, general or abdomen, again, they're looking, even though you can look at the uterus and ovaries and the pregnant person, also if there's not a pregnant person in the abdomen area, they can look at the liver, the gallbladder, and the kidneys. Breast imaging is there as well. So with those, if you're doing an ultrasound of the breast, they're looking for cysts, they're looking for lumps, etc., so that they can make a diagnosis. This is usually after you have a mammogram, this is usually the first step. They might send you for a breast ultrasound before they go and do what do you call it? Uh, I can't think of it, but basically they go and they take a tissue sample and aspirate it out, and they send that tissue to the lab to detect whether or not it has cancerous cells, whether it's benign, etc. or cancerous. And then some techs work in musculoskeletal, so they're looking at kind of the joints, the tendons, and the muscles of patients. So basically, in order to specialize in these different areas, they typically have these 3 different tracks that you see at the bottom: OBGYN, general, and then also cardiac. So you have to specialize. So again, just like X-ray, you can move into the different modalities. Once you get sonography, you can get different modalities or certifications as well. And you can be all of these if you want it to be. All right, the next modality is MRI. All right, so MRI really it uses a magnetic field and also radio waves to create the images that they see, very detailed images. So the radio waves or the radio frequencies send pulses into the body. And as those pulses are being sent into the body, we have hydrogen atoms that absorb those energies and they release it back. And that release energy is what becomes that MRI signal. So the patient actually creates the signal or is the source of the image. The machine is kind of like our gamma cameras. They're just detecting the energy that's coming back from the patient's tissues. So it is non-ionizing, so it doesn't use X-rays. It only uses the magnet and also radio waves. It is safe. But there are like really strict protocols when it comes to MRI. I don't know if you're privy to, within the last year or so, there was a gentleman up north. Somehow he came to the MRI magnet to see about his loved one, and he had on some sort of chain, and that chain sucked him into the MRI bore. And of course, as a result, he did die. The magnets themselves, they are rated in Tesla. So that's the measurement of the magnet strength. And also, the quality of those MRI images do depend on, of course, the strength of the magnet. So kind of like you get what you pay for. But before you can get an MRI, there is basically a screening form. It goes over things like if you have anything in your body, like an implant, what type of implant. They even may go down to figure out what's the serial number on the implant to see if it's MRI safe. Because the last thing you want to do is go in MRI machine and having whatever's within your body being sucked out, basically snatched out of your body. Some people may need a screening X-ray of their orbits, especially if they work, let's say in welding, because if there are any metal flakes within the eyes and you go for an MRI, of course, it could snatch the metal and, of course, damage your vision, potentially blind you. Some tattoos have, a metallic component. So they kind of and with that being said, when you get into the magnet, if it's interacting, if it has that metallic component, it can actually burn your skin. So that is usually on the screening form. And then also any type of other implants, whether it be tooth implants, whether it be like knee replacements, hip replacements, shoulder replacements, etc. All those things have to be scanned, and they also have to be magnet safe before they actually put you in the magnet, to include, let's say we wheel a patient in on a gurney, they have oxygen, we need to clean the room. Everything that goes in that MRI magnet or near that MRI or past that threshold needs to be MRI safe. All right, so in terms of The magnet, it cannot scan ferrous materials. Ferrous means that it contains iron and it is strongly attracted to the magnet. So some of the examples of things that might contain this element are going to be pacemakers. So again, if you have one, they have to deem it MRI safe before you can get that. Some aneurysm clips might not be safe or rated safe for MRI machine, so you might not be able to get the exam. Metal fragments, also old surgical implants. Again, that magnet basically has strength enough to pull that metal out of you, and that would cause, an injury, to include if we're talking about the eyes, blindness. If it's something that's keeping your body functioning, it could even result in death. So again, even though the MRI system is great at checking things like soft tissue, inflammation, infection, tumors, looking at your brain anatomy, also spinal cord issues. If we have anything in our bodies that would not be rated MRI safe, then you cannot have that MRI. So the MRI rooms, they're typically shielded by what we call a Faraday cage. They usually will block out, or that cage usually blocks out radio waves so that they don't interfere with the patient's scan. So again, if you haven't been checked, no one should go past the threshold of the MRI door. All right, components of your MRI machine, just like your CT machine, it does have a gantry, so that's that large donut-looking thing. It does have a patient couch, just like the CT machine, that moves the patient into the bore. Additionally, it has what we call RF coils, and they collect that MRI signal. The coils can be internal or they can be external. It also has gradient coils that shape the magnetic field to help form the image. And then, just like all of our systems, it has a computer system that is going to control the scan or control the sequences and actually help reconstruct the patient's images. All right. In terms of the actual fields, high field MRI machines, we're talking about things that are greater than 1 Tesla. Those scanners usually have superconductivity, meaning that they stay extremely cold, and they stay extremely cold using liquid helium. That's how we keep them cold. Some of the concerns for MRI machines: one, they're small. So some patients may be claustrophobic and may need some type of medication before they can get the scan, or even put under or sent to an open MRI unit that doesn't have that donut or gantry configuration. And the purpose of the liquid helium is to keep what we call resistance or electrical resistance as low as possible or at zero, and that allows the magnet to run continuously. If there's something that happens to the unit that means that we need to shut it down, it's very expensive to shut that MRI machine down and bring it back up. So again, patient concerns are claustrophobia. Another thing about the MRI machines is they are very loud. That gradient coil vibration makes it very loud. Some units have like headphones that patients can use to listen to things, but it is a very loud unit. And the different sequences that the machine has to run through has a lot of, when you're in there, when we're talking about being loud in terms of the vibration, there's a lot of knocking and clunking going on. So again, if you're already claustrophobic, that is going to just exacerbate your exam for you. So again, some patients have to be sedated before they can have their exam, and then some patients have to be medicated before they can have their exam. And then some patients, due to claustrophobia or maybe size, they have to be sent to an open MRI unit. All right, moving on to where the MRI signal comes from. So the MRI machine or scanner, basically, again, it detects that energy that's released from those hydrogen ions or atoms, hydrogen atoms within the patient. So the patient themselves actually helping to make the image, and the coils, the RF coils, kind of act like the antennas to help pick up the signal. So in terms of the types of coils that the units have, the coils can be external or internal. If they're internal, they're built into the gantry. If they're external, they're placed on the patient's body part. So you can have those two types. The gradient coils themselves help determine where the MRI signal is coming from, and they also help determine how the image is actually going to be formed. So they also, those gradient coils also create, you know, that loud noise, that loud tapping noise that you hear if you've had an MRI exam or you've been near an MRI suite. You can notice that the noise within there is significantly louder. MRI safety zones are really important. Going back to the gentleman that was sucked in, it has 4 safety zones, and that's ranging from public areas to the actual room where the magnet is actually housed. There are, again, strict safety protocols that are required, and the reason why they're required, training and these protocols are required, is to prevent accidents that could result in the death of a patient, or having to cool the magnet down, take the magnet down to fix whatever the issue is, whether it's a mop bucket that's stuck to it or a gurney that got sucked up to it, because it was not MRI safe. So again, the MRI signals come from the patient. Those signals are collected by the coils, and then they are shaped by the gradients. And of course, the safety rules that surround MRI magnets are very, very strict. All right, next we're moving on to radionuclide imaging. So here we're talking more so about nuclear medicine. It's another modality you can get into. Of course, there's more school that goes along with it. And with this one, we're kind of looking at basically organ function, kind of like fluoro, but here we're actually, using radioactive isotopes. So we're looking more so at how the organ works, not just how that organ looks. So it's especially good if we're checking for things like tissue perfusion, which means basically how well the blood is flowing through an organ. So basically with this one, you're going to give the patient what we call a radiopharmaceutical, which is a tiny amount of a radioactive material, which we call a tracer. That tracer is going to travel to the part of the body that the doctor wants the study on. So of course the tracer is going to be attracted to that body part or area of interest. In terms of what we call radiation emission, the tracer itself gives off gamma radiation, which is basically high energy light. And we use a gamma camera to actually detect that gamma radiation. Gamma cameras themselves, they pick up the radiation. Again, that radiation is coming from the patient. So the patient is actually radioactive at this point. The cameras can have can be manufactured or built with one camera head or a single head system, or they can be built with two camera heads or a dual head system, which gives it, faster. If we have a dual system, it gives you faster and clearer images over the single head system. So again, nuclear medicine, we're using radioactive isotopes, making the patient radioactive, and we're detecting that radiation that they're giving off with the gamma camera. All right, again, in terms of what we use in nuclear medicine, we use radionuclides. And these are, again, radioactive isotopes, different tracers that are prepared in what we call the hot labs. They have different half-lives, meaning how long they are going to stay, or the patient is going to stay radioactive. One of the more common ones that they use in nuclear medicine is technetium-99. And the reason they like that one is because it not only gives us good quality images, but it also, the half-life is shorter, so it wears off a lot quicker. Different types of nuclear imaging are SPECT imaging, which stands for single photon emission, computer tomography. So it gives them more of a 3D image. So it basically rotates the gamma camera around the patient. And then we also have PET imaging, which stands for positron emission tomography. That one, they can use it or use it to detect cancers, because the cancer cells absorb a lot more of the tracer. And then with that, we can have hybrid imaging. So when we say hybrid imaging, more modern machines, they can combine PET and SPECT with CT and also MRI. So they create what we call fusion images, and those images are able to not only show the function and how the organ works, but they can also show the anatomy or the exact location inside the body. So again, this is more modern. The hybrid imaging machines are the more modern type. All right, next we're moving on to radiation oncology. This is basically a field where they use high energy X-ray photons or electrons to treat cancer. So we're talking more so about radiation therapists. Those photons or X-rays, as they are intercepting the patient's body tissue, their goal now is not to make an image, but their goal is not to make an image like us, but their goal is to actually destroy those cancer cells by damaging the DNA so they don't continue to proliferate or grow. Part of cancer treatment, which radiation oncology is where that patient would be going, part of cancer treatment might consist of radiation therapy. It can also consist of chemotherapy, surgery, and sometimes immunotherapy, depending on, what the patient needs. So it's really more so a team approach with this group of people. When I say team approach, there's a group of specialists that are involved. So you have your radiation oncologist, which is the doctor that helps plan the treatment, or that basically plans the treatment. They work with a medical physicist that ensures that the dose that the patient receives is accurate, and also they do make sure that the machines that the techs are using, or therapists are using, are operating safely. Their team also consists of a dosimetrist, which is something or a field that therapists can move into, but dosimetrists basically calculate the correct dose. And also they plan the angles of the beams that the therapists need to use. There's usually some sort of nurse navigator that these patients will have to kind of support them throughout the whole journey along the way. And then, of course, last but not least, we have the radiation therapist, and the therapists actually use those treatment plans to treat the patient, operate the machines that treat the patient. All right, so they're like the nurses, I guess, of imaging, because they're more so on the treatment side. They're going to see that patient all the way through from the beginning to the end of their treatment. So whereas we in X-ray, we're more like a high and by. We roll in, we take the image, we leave, and we may or may not see that patient again, depending on what they're there for. So again, the purpose of this particular group is basically to treat cancer patients. So intended to again destroy those cancerous tissues, and the types of treatment that therapists might engage in are going to be curative or palliative. So curative means they're trying to completely kill that cancer or remove the cancer, or palliative, they know that they can't do anything for the patient outside of helping to reduce the symptoms or the pain, because they can't cure it. So those are the two reasons why a patient might be getting radiation therapy. All right, the oncology team itself, again, the entire team, they are focused on treating the cancer that the patient might have. And again, some goals that they might have is to shrink it, so that they can potentially go on to surgery to have it removed. All right, the smaller it can be, the less tissue you have to remove, or their goal overall could be actually to destroy the cancerous tumors. All right, now in terms of the equipment that therapists use, they can use what we call the they use or can use what we call the LINAC machine, or the linear accelerator. So basically, this is how they deliver that radiation to the actual area that they're interested in treating. So the machines themselves, there's two types of energies that they can give. They can deliver high energy X-ray beams, or they can deliver electron beams. So photon versus positron. And in terms of the energies that are needed, they again can use high energy X-ray photons to treat deep tumors that are deep inside of the body, or they can use electron machines or photons to treat those surface level tumors like skin cancers or anything near the skin surface. So that comes back to treatment planning. Every patient that goes into there, it's not like X-ray where everybody's just going to get the same thing. They need a foot X-ray. This is our protocol. We're going to do a AP, we're going to do an oblique, and we're going to do a lateral. Everything is customized to the patient when it comes to their treatment planning in radiation therapy, because all cancers aren't alike. So the computer basically calculates exactly how much radiation is needed, where that radiation needs to go, and it also they also try to ensure that they only treat the area that they need, and treating only the area that they need helps avoid damaging healthy tissue. All right, now in terms of advanced capabilities of those LINAC machines, some of the more modern ones, they can perform special techniques such as IGRT, which is image guided radiation therapy. So they use images to check the patient position. Then you have stereotactic precision, which is, targeting, meaning you're very accurate when you're targeting very small tumors. And then They also have IMRT, which is intensity modulated radiation therapy, where the shape of the beam actually matches the actual tumor. And the goal of that one, again, is it goes back to sparing the healthy tissue. You don't want to treat the healthy areas because, this radiation doesn't discriminate. It's gonna it's going to damage the healthy cells just like it's trying to damage the cells it's interested in destroying. All right, in terms of the treatment rooms for radiation therapy, they're pretty large. In terms of patient comfort, I guess all rooms we hope to design them with patient comfort in mind. And then also with that, the reason why patient comfort and the rooms being aesthetically appeasing are important because again, those patients are with you for a period of time from the start of their treatment until the end of their treatment. And that can be several weeks. Sometimes depending on if the treatment has to drag out, it can be, months as well. So again, the treatment rooms are pretty large. And also, I'm pretty sure that their rooms are lead lined as well, more lead than what we have in our x-ray rooms. Their door is even very heavy and also leaded as well because, again, we're talking about a lot of radiation going on in there that we don't want to get out to the public and we don't want to get out to the techs that are right there in the control area. All right, now we get down to basically the conclusion of this chapter. So we talked about some definitions. The two definitions that we first talked about was diagnostic yield versus diagnostic efficacy. That's that word I was trying to remember before you all left. And the main goal again of imaging, we want to create the most useful image with the most accurate information. And then also we want to make sure that we are choosing the right modality for it. All right, in terms of radiographic equipment variety, we talked about different types of imaging machines per modality. We talked about how some of them share similar parts and also similar functions. In terms of digital technology, that's more so on the fact that we're now using those digital receptors instead of film. Or even, going away from the CR technology, which is still digital, but it's not as efficient and fast as your DR detectors. In any case, with the CR detectors and also with the DR detectors, they create electronic data sets, which will be turned into a signal, and that signal, of course, will show up as our manifest image. We also talked a little bit about some advancements in terms of digital detectors and how they continue to evolve, and they allow for new ways for us to take x-rays at, of course, a lower, also safer dose. And of course, we're more efficient because we can get that image faster. And then the last slide of the chapter, still in that same realm, but with our digital equipment, it makes for not only better images than we used to get back in the film screen days, the equipment also provides us more efficiency. All right, our basic x-ray principles are still going to be the same. So even though the machines are more advanced, the physics behind it all, the x-rays are still made in the same way, meaning the electrons will flow from the cathode, strike the anode, and create the x-rays for us. The goal of all of the equipment, no matter the modality, is to get the best possible clinical image. Of course, if we're talking about the ones that create radiation create x-rays or radiation. With those, we want to keep that radiation dose as low as possible. So operating on that ALARA principle, as low as reasonably achievable, meaning you as the technologist, you need to always use the lowest dose in terms of your mass and the KVP that you set, but not so low that we're not going to get a diagnostic quality image and it's going to be a repeat. So again, even though we have improvements with that digital image quality, we still need to operate our equipment safely. We still want to ensure that our techniques are low as possible to ensure that the patient has the lowest dose possible, but also we want to ensure that even though may have the lowest dose possible, the technique does still need to be high enough to yield a diagnostic image, meaning it's not noisy, grainy, or mottled, which would basically tell us that it's an automatic repeat at a higher technique. So that concludes our lecture for the week. Hope this helps, and I will see you next week.